Steph, thank you for doing this. I really appreciate your time. So let's start by your previous role, then what you're doing currently now.
hmm
So before you delved into the world of PrEP, you were a specialist HIV pharmacist. So for audience who don't really know what HIV is or actually have a very basic understanding of HIV, what would you tell them? What is HIV? And perhaps you can then talk about how is HIV treated.
Sure. So HIV is a virus which can be transmitted in a number of ways. It's a bloodborne virus and it can be transmitted through sexual contact, intravenous drug use, needle stick injuries, and it seeds itself into the host genome and infects a person. Currently, there's no cure available, so it's a chronic condition. So once infected, it's a lifelong condition, essentially, similar to any other chronic condition. And it's treated with antiretroviral medication. And there's various different classes of antiretrovirals. We're very lucky that we've got a lot of drugs available to treat HIV. And if you take the medication every day and you're adherent to the medication, then the HIV shouldn't affect your life in a day-to-day way. There's oral medication, which has been our kind of mainstay of treatment for the past couple of decades. And now there are single tablet regimen available. So that's just taking one pill a day to control the virus. We've even got injectable drugs for PrEP now, for HIV treatment. We're going to come to PrEP later, no spoiler there. And that's a 2 monthly injection of 2 HIV medication, which can be used solely to treat HIV. So there is an option now for people not to take any tablets at all, which has been quite a game changer in the field of HIV. The other thing is that was published quite a few years ago, something called U equals U. So if you take antiretroviral medication every day and it brings down the level of your virus to undetectable. So essentially, undetectable means if we test the blood for the HIV virus, it's at such low levels that we can barely see it on the blood screen. So we term that undetectable. And undetectable equals untransmissible. So U equals U. So essentially, if you're taking the medication adherently and your virus level is undetectable, there's virtually zero chance of transmitting the virus to someone else. So this has been a huge breakthrough in the field of HIV, and it's given people so much kind of confidence in the medication, a lot of empowerment, allowing people to have sex, bear children without having to worry about transmitting the virus, and taken away a lot of the stigma associated with the condition. So I think for now, the main problem with the disease is the stigma, because we know that the medication works, we know it's effective, we know that they're really quite powerful medication in terms of like their barrier to resistance, but it's just the stigma which is affecting the disease and is still to this day. Yeah, we've still got a lot of more work to do, I think.
Right.
But in terms of treatment options available, I think we're very lucky that we've got these choices in terms of lots of different medication classes and now injectable
Yeah.
medicines as
Yeah.
well.
So I think to summarize, HIV is a viral infection and we can actually treat it. It's not the end of life sentence. You can actually have medications, you take it regularly, and off you go with your daily life, which I think is quite an important message to spread across, which a lot of people don't really are aware of. And I think another important thing you said is the difference between treatment and cure, that the cure for the virus still doesn't exist. So as things stands, we have to take tablets regularly.
Yeah, there's a lot of trials that have been conducted looking at cures and a lot of work with vaccines for the HIV virus as well. So a lot of the data and evidence of designing HIV vaccines was used to develop COVID vaccines, and that's how they developed some of the COVID
Oh,
vaccines
wow.
so fast. But unfortunately, the HIV virus is very clever.
Yeah.
and it seeds itself in what we call reservoirs in the body. So lots of different areas in the body that the drugs can't penetrate fully. So the drugs can get the level of the virus down to such low levels, which we term undetectable, but it won't get the level to zero,
Yeah.
and that there's absolutely no virus in the blood. There's lots of cure studies happening, but we're not quite there yet.
Yeah.
But who knows
That's
in the
fair.
future?
That's fair. Let's talk about global statistics. And I'm sure you're aware of it, but just from the audience point of view, I'll just talk about the very basics of them. So as of 2023, nearly 40 million people globally are living with HIV, and 1.4 million of them are children. In terms of deaths in 2023, 630,000 people died from HIV-related causes, and 76,000 of them were kids. And HIV continues to be this global public health issue. And since we are aware of HIV, it has claimed up to 42 million lives, which is a fascinating fact in itself. And in terms of new infections, you would think that with all the treatment that we have, even after all of that, in 2023, 1.3 million people acquired HIV, and of that, 120,000 were children. These are just staggering facts. Based on that, let's talk about the risks of HIV. Who is at risk? Are there a particular cohort of people or population that is at higher risk, or is everybody at equal risk who has sex?
Not everyone that has sex without condoms is necessarily at risk of HIV. So we know that gay and bisexual men who have sex with men, the prevalence of HIV is higher within this particular community. That is one of the largest groups at risk. But there are multiple other groups as well. So for example, if the partner that you're having sex with is HIV positive or living with HIV, and they're not on treatment, and which means they don't have an undetectable level of the virus. So in that instance, we would think about HIV prevention. Other risk groups, so thinking about sex workers, anyone that pays for sex or gets paid for sex work. Thinking about heterosexuals as well. So particularly though traveling to countries of high HIV prevalence. So thinking about Black African communities, heterosexual men and women, and also for partners that have multiple other partners and that may not be able to negotiate condom use, for example, and then injecting drug users.
That's right, yeah.
But also, so people that have multiple partners, people that engage in group sex or something called chem sex,
Yes,
which
drug
is
sex under influence.
exactly. So taking kind of any form of drugs in and around the time that you have sex. People that have had multiple previous STIs before.
Yes.
So anything like chlamydia, gonorrhea, syphilis. And people that are having sex with people from any of those high-risk groups as well. So, for example, as a heterosexual woman, if I was having sex with a bisexual man, then that would be a
Would you
risk.
add increased risk?
Yeah,
Fine.
yeah.
Fine. I think you touched the concept earlier about U equals U, and which basically you said that if somebody's stable on treatment, taking it regularly, and their virus level comes to what we call undetectable level, means that they are not able to transmit someone. I think that was a huge step within the HIV world. And I think that really protected a lot of people who were partners, right?
Yeah.
But I'll tell you another fascinating, I think UNAIDS came up with this statistics saying that 23% of HIV population globally still does not have access to antiretroviral therapy. So that's nearly 1 in 4 people, right? So one of the strategies could be that you find these people, you bring them onto ART, and you get them to undetectable level. but it seems to be more difficult to try and get everyone in. So I suppose another strategy to protect high risk groups from getting HIV is something called PrEP, or pre exposure prophylaxis. And you are currently dedicated to this field and it's your full time job. For people who don't really know what PrEP is, how would you define PrEP?
So I guess like PrEP stands for pre-exposure prophylaxis, and in sexual health we associate that with HIV prevention. But PrEP is like a well-known terminology within like the medical field. So PrEP could be anything really, any kind of medicine preventative. So a similar example would be like doxycycline for malaria prophylaxis, that's
Right.
preventing you from getting malaria by taking the medication. So in HIV, pre-exposure prophylaxis is taking medication to prevent HIV acquisition. It's a form of HIV prevention. It's not the only form of HIV prevention. There's other strategies which I think are really important to mention. So, for example, condoms,
Yeah.
circumcision. There's lots of other forms
Abstinence.
of HIV.
Not having sex.
Yeah. PEP,
Yeah.
post-exposure prophylaxis. So these are all other strategies as well. HIV prevention as PrEP is very effective. And we've seen that through trial data. And when it first came about, it was an oral medication under the brand name Truvada, which is two different medications. So it's tenofovir disoproxil with emtricitabine, comes in a little blue pill, not the nice one though. And it's essentially taking the tablet in and around the time that you're having sex to prevent HIV acquisition. There's different ways of taking it depending on the type of sex that you're having. So, for example, if you're having receptive vaginal sex, then you would need to take PrEP daily. So 1 tablet daily all the time.
So that's a woman, receptive vaginal sex.
Yeah. But if you were having insertive anal sex, for example, or receptive anal sex, you could take PrEP as something we call event-based dosing. We sometimes call it on-demand dosing, or PrEP when required, essentially taking the PrEP around the time that you're having sex to protect HIV. And that's taking 2 tablets, so a double dose on the first day. That's got to be at least 2 hours before sex. And then 1 tablet the next day, around 24 hours after the last dose, and then 1 tablet the day after. So in total, it's 4 tablets, a double dose on the first day, and then 1 tablet daily for 2 days afterwards. So this is really beneficial. It prevents pill burden. If people don't want to take tablets every day, reduces the longer term drug exposure that you're having on the body. But I guess the downside with it is you've got to be really adherent with those doses. So there's no leeway, there's no buffer with the event-based dosings. If you miss any of those doses, the first day, the second day, or the third day, we would probably ask you to come in for PEP, post-exposure prophylaxis. Whereas if you miss 1 day of the daily dose, we know with clinical trial data that's okay, and the drug levels would still be sufficient to prevent HIV acquisition. So people on event-based dosing, I really reiterate the importance of adherence. I get them to say the dosage back to me and asserting kind of how often they're having sex and the type of sex. So is it planned? Is it spontaneous? Are they going to have time to take the double dose before? And if they're having sex twice a week, for example, there's no point doing event-based dosing. You may as well just take it daily. So yeah, there's pros and cons of both dosing. The other one, which I haven't mentioned, is something called T's and S's, which is taking PrEP daily on Tuesday, Thursday, Saturday, Sunday, taking 4 tablets a week, which has been trialed in the MSM cohort, men that have sex with men. And it's proved effective enough to prevent HIV acquisition. We sometimes use that as a strategy in clinic for people that struggle to take daily doses, struggle with side effects of the PrEP, and like that pill burden. But again, similar to the event-based dosing, you've still got to be quite adherent with that dosing, because if you're missing more than 2 days in a row, that's where we fall into a bit of a grey area, and we might need you to come in for PrEP.
Makes sense.
So
Makes
that's,
sense.
yeah, that's a long answer for what is PrEP, but hopefully
I
kind
think
of
it's
answers the question.
very informative. So PrEP is basically a tablet that you take daily and you're not going to get HIV.
Correct. So it won't protect you from any of the other
Yes.
STIs, which is really important to mention. There is potentially doxypep coming, which is doxycycline taken after sex to prevent STIs, which is happening around other parts of the world. We haven't got it yet currently in the UK
Yeah.
NHS, but let's not
Yeah.
take
I
things
mean,
even further.
that's
So
for
yeah,
next episode
there's
when it actually
watch
becomes,
this.
yeah, watch the space. Okay, talk about the timeline of PrEP. This concept of PrEP came into existence. I'm trying to think. I think in America it came first around 2011, 2012, and then CDC approved it. And then WHO then recommended it for high risk group in 2015. That's based on my research. But UK seem to have not really, they weren't very quick. Is that correct? So I think from what I remember in the UK, it was 2020 when PrEP was available on NHS. So,
Yeah.
so there was a bit of a fight happening between 2015 and 2020 within the HIV community to try and get PrEP to the country. So what happened in the UK during that time?
Yes, the NHS require more data in the UK and got sexual health clinics to do something called the Impact Trial, which I believe started around 2018, 2017, where sexual health clinics would basically recruit people to go on to PrEP. And it was quite marketed towards the MSM cohort. And it was over recruited. They were constantly adding the number of people that they could have onto the trial, but it reached capacity quite a lot.
Yeah.
So what was happening is people were just buying PrEP online.
Yeah.
I know Chelsea and Westminster Hospital did a lot of work in terms of looking at the tablets which were being sold online and whether they were reputable, adequate drug levels. And they were able to advise patients on reputable websites to buy PrEP online. And then they would provide some of the monitoring to go alongside it.
I think there was a website, I want
I
PrEP
want
now.
Yeah,
Yeah.
that's right. Yeah,
.co.uk.
that's right.
Yeah.
So, yeah, so that was about 2017, 2018, the Impact Trial. And then, like you said, 2020 is when the NHS formally commissioned it to be available
Yeah.
through sexual health clinics only.
It's insane how it took us 5 years to realize that this is a simple intervention that is so effective. And from its start, from 2012, it took us almost 8 years to
Yeah,
for it to come into.
I think there's a lot of controversy around PrEP, and I think there was a lot of possible opinions that it would be promoting promiscuous behavior and kind of that kind of negative connotation. And that's why I think it took a bit of time. I think Truvada coming off patent and becoming generic, so the price dropping massively.
I think it was
Probably
10 times or something.
Yeah, had probably played a significant factor into it then being commissioned through the NHS. But we got there eventually. Yeah,
Amazing. And now we're saving lives through this intervention. Well,
we try.
you
We
are.
try.
You are a PrEP pharmacist. And I think it would be fair to say that, as far as I'm aware, when you started doing this job, you were one of the only full-time PrEP pharmacists in the country, right?
Yeah, so a couple of years ago when I started, yeah, that was correct.
So what is a day in life of a PrEP pharmacist?
Good questions. Yes, my I guess official job title is PrEP and sexual health pharmacist. And yeah, my role probably has two hats to it. One half is PrEP, one half is sexual health. So with the PrEP side, I do a clinic, a face-to-face clinic, where I see people on PrEP who may have more complex issues related to PrEP, for example, side effects. So they may not be able to manage taking the medication because of most commonly GI side effects, stomach type side effects, or so Truvada, the generic Truvada, which is our routinely available PrEP, can have some long-term issues in terms of causing kidney impairment and bone problems. So with the kidneys, it is a chronic side effect over time. So it doesn't necessarily cause acute kidney
Doesn't happen
failure
straight
requiring
away.
dialysis or
Yeah,
anything
yeah,
like
yeah,
that.
yeah.
But it can affect the kidneys over time. We've had people on PrEP who've been on it since the impact trial, since 2017. We're coming up to 7-8 years now, potentially being on daily PrEP, which can have an effect on the kidneys, particularly those with other kidney renal risk factors like diabetes, high blood pressure, age. So I will see people with those complexities.
In terms of characteristics, if I were to say, who walks in to your clinic asking for PrEP? Are they young people? Are they mainly male? What is it? What is a characteristic
It's
of
everyone. It's absolutely everyone. So from age, I see from 16 to I think the oldest person is around 92. I have
wow,
that I see. So he's quite, yeah, my inspiration.
he's living
Um,
life. Much more interesting
yeah,
than mine.
what else are you gonna do at that age, you know? And yeah, genders again, anyone, women, men, transgender, male, transgender women, non-binary, and their indication for PrEP can also vary as well. So it could be a woman who's having sex with bisexual men. It could be MSM. It could be Black African heterosexual women whose partner is suspected to have other partners and traveling back and forth to Africa. It's so varied. And that's probably my favorite day of
Yeah.
the week is my clinic. And then I also do virtual complex PrEP MDT, where I work with some of the nurses, consultants, and HIV trainee doctors, registrars, and we meet up once a week and people get referred to us to discuss. So again, it could be like kidney bone issues, side effects. It could be any kind of complex issue that the clinician feels needs some kind of extra review. So yeah, we will review the patient, and if we feel like we need to recall them in for a repeat kidney test, or I might book them into my face-to-face clinic to be seen, or we'll do telephone consultations, or we'll be able to confidently say, actually, you know what, that kidney function test was probably because they were having a load of protein shakes that morning and dehydrated. That's okay. We can wait another 6 months until they come back and repeat it again. So that's the kind of PrEP side of
Nice.
my role. But then also I have a big kind of like education and training role. So
Very nice.
yeah, awareness, teaching clinicians about the eligibility for PrEP,
Right.
that it's not just MSM, upskilling our staff, so making sure kind of the nurses are working under PGD to be able to work autonomously to see people for PrEP. We've got health advisors in the clinic who are essentially like trained counsellors who see a lot of our PEP cases and now trained in PrEP. So if they're seeing someone for PEP, they can quick start them on PrEP to start PrEP after they've
Wow.
finished the course of PEP. And then the other side of my role is sexual health, medicines management, stock issues, my favorite, or governance, guideline writing, PGD writing, that kind of
See,
stuff.
wearing a lot of hats, basically. So maybe sticking to the PrEP theme, can you tell me an example that comes into your head? Somebody who came to you asking for PrEP and how PrEP changed that person's life. Like this, we always have one of these examples that really stick into your head. Could you think of an example?
There's one lady that sticks out quite a lot, I would say. So I met her about a year and a half ago now. So she'd come to our clinic requesting PrEP, and she'd basically been to a clinic before us, which was her local sexual health clinic. She'd been there twice to try and get PrEP. The reason she wanted to get herself on PrEP, she was a Black African lady. Her partner was traveling and she suspected he was having multiple other partners.
Traveling to high-risk country.
Traveling to Africa, Nigeria. And she wanted to get herself on PrEP. And she'd gone to the sexual health clinic. And the response from the clinicians that she saw was that she's not eligible for PrEP. She doesn't meet the criteria.
Wow.
And the response to her was just stop having sex with this partner, or
Really?
just use condoms. That was the response that she got. And she also made them aware that she was in a domestic abusive relationship, and that just wasn't.
Yeah, condom may not
It
be an
wasn't.
option if the guy's going to say,
But she persevered and she came to our clinic,
oh, thank God for
which I'm
that.
so grateful for, and grateful to our clinicians who saw her, who were able to get her onto PrEP. And I was able to see her in clinic and continue her and refer her to our kind of health advisors who could help support her with kind of trying to make her more safe in the relationship, refer her to other services that can help support domestic violence victims. And now she has got out of that relationship and she actually doesn't need PrEP anymore. But she spoke about how empowering it was for her that even though at the time she couldn't get out of that relationship, PrEP gave her one part of control within that relationship, that she knew that she would be safe in terms of any HIV acquisition. And that meant so much to her. And yeah, I would say it was just, it's quite emotional. It's just when you hear this story, you just think, oh my God. And it was just, to be able to offer that to someone to make that much difference. And it's so upsetting because she shouldn't have had to fight so hard. And these are the most vulnerable groups. We've looked at like the UK HSA data, which has shown that of the new HIV diagnoses, the most two common people that we're seeing are Black African women and the MSM community, but they're on par. So it's around a third MSM, white MSM, and a third Black African women.
Wow.
But PrEP users, we're just not seeing those people at all. So they're so at risk.
Yeah.
But it's tricky because they may not know about PrEP to begin with. It's not as it's not as widely talked about within that community, whereas in the MSM community it's widely talked about. The HIV status is talked about before sex. If you're on PrEP, if you're off PrEP, if you're HIV positive, if you've got if you're undetectable, that's widely talked about, but not within the Black African community. So A, PrEP isn't known. B, even if PrEP is, they may not think it's for them, and they may think, oh, actually, no, that's not for me. And then if they do realise, oh, actually, I need PrEP, they've got this situation where potentially they're going into a clinic and being turned away for eligibility. Now, I don't want to paint a picture that this is every clinic, and I don't believe it is. I hope that this was an isolated event, and this was 1 or 2 years ago. Things have moved on quite a lot since then. But not only that, trying to get an appointment for PrEP in sexual health clinics is a nightmare.
It's a nightmare right now, yeah.
Depending on the clinic, they may offer a walk-in system or they may offer a system where you book online for appointments. We offer both. In reality, that means getting up and being at the clinic for, I would say, 7:45 in the morning.
Wow.
During the week to join the queue at the chance of being seen on that day, or you may have to come back the next day and join the queue again. And then if you want to book online for a PrEP appointment, they just go like this. As soon as they're released online, I would say, like, I release my slots. If I've got a free clinic and I haven't got anyone to book into, I'll open up some online slots and see some routine PrEP cases. People, and I will release them like on a Wednesday morning. By about 30-45 minutes later, they're all booked up. It's mad.
Yeah. I think the funding cuts that the government announced in sexual health doesn't really help the situation with PrEP as well. And only time will tell, like, the overall impact of it. Moving on to side effects, you mentioned that PrEP, the most commonly used tablets, Truvada, or the generic version of Truvada, has some side effects. So, if patients who are taking Truvada get side effects or for whatever reason can't take it, but they want to continue PrEP, what are the other options people have currently?
Yeah, great question. And I think this is so important because if people get side effects, it's important that they don't just suffer in silence and stop PrEP.
Yeah.
They must come back to the clinic because there are other strategies, there are other medicines that we can offer now. And I did a review of the last 4 years of new HIV diagnoses that we saw. And of the people that were on PrEP that acquired HIV, they'd stopped PrEP because of side effects. So it's just so important to get that message out there that we can offer other strategies. And that's my job. Okay, so I would say short-term side effects are GI related, so gastrointestinal. So you're looking at nausea, plus or minus vomiting, feeling a little bit bloated, abdominal pain, diarrhea, flatulence, those kind of things. Now, this is normal
Yeah.
when you start taking PrEP, and we advise to persist with it for the first couple of weeks, and then your body builds up a tolerance. If that doesn't happen, there are other strategies as well. So we would say switch to the daily dosing, because if you're taking the tablet daily, you're more likely to build up a tolerance. Rather than the event-based dosing, you're taking a double dose, which is a bit more of a hit for the body and less often. So the body hasn't got time to build up that tolerance. We then look at asking them to take the medication with food. So having food first and then taking the tablet with food, or taking the tablet within 20 to 30 minutes of taking the tablets. And food acts as a kind of protectant for the stomach for what it's about to receive. So that can really help with those kind of side effects. Switching times of day is another one as well. So if you're taking it in the morning, try taking it at night, vice versa.
Sleep through cycle.
Yeah, some people fast in the morning, so they're not having a big breakfast. So try taking it at your first meal or something like that. Some people suffer with lactose intolerance. Now, the PrEP contains around 3 mils of cow's milk. It's tiny amounts, which shouldn't have an effect.
Yeah.
But it's difficult to know if it's the lactose intolerance or just the PrEP side effect.
Right.
Because both of them can precipitate in the same way.
Right.
But we would advise to take like lactase enzyme tablets. We can get different generic brands in, which you would think, why would that make a difference? Because it's the same active drug, but it does. And I don't know if it's a bit of a placebo effect. I'm going to give you this different medication but there are different bioavailability with generics. So you might get higher drug levels in the body than taking another PrEP tablet, still having the effectiveness of HIV protection, but it might not precipitate those side effects. And then if we've tried all of those things, sometimes we may say to go to the T's and S's dosing, Tuesday, Thursday, Saturday, Sunday.
Which we discussed, yeah.
Sometimes we may say to take half a tablet or a quarter of a tablet and build yourself up taking one tablet.
Right.
Now, this is in a really controlled setting where, for example, we know that they're not having any condomless sex.
They have to use additional barrier methods when you're doing that kind of stuff.
Right. That they're adherent, because there is a huge risk if they're taking half a tablet of PrEP and they acquire HIV. There's a risk that they will develop a resistant virus, and then we're setting them up for a bad position when they come to their new diagnosis appointment, and there's limited drug options then available. So that's the kind of short-term side effects. Then the longer-term side effects, which we discussed with the kidneys and the bones.
Kidneys and the bones, yeah.
So again, it's long-term that we see these side effects. And with the kidneys, you could use the strategies of switching to event-based dosing, because it's less tablets over time. But it depends how often they're having sex, because if they're having sex more than once a week, there's just no point. With the bones, most people will tolerate the medication fine and will be at pretty low risk for acquiring the bone toxic effects. And with the bone toxic effects, I'm talking about it reducing your bone mineral density.
Makes your bone brittle, basically.
Exactly. How heavy are your bones? How risk are you to a fracture if you have a fall? And Where I'm worried about PrEP would be, for example, in postmenopausal women, people who are heavy smokers, people immunocompromised, for example, going through chemotherapy, people on long-term steroids.
Yeah.
If I see, or young people, when their bones are still developing, 18, 19-year-olds, the bone's still forming at that stage. So with the kidney and bone toxicity, we do have a new drug for PrEP available. That's called Descovy. So that was commissioned by the NHS May 2023.
So there is hope for these people.
There is. So Descovy is very similar to the routine commission pill. It's still a blue pill. It's smaller there. It's about half the size. And it does contain tenofovir and emtricitabine, the same as the routine PrEP, but the tenofovir has changed slightly.
The salt is different.
Exactly. You know this already. Why are you asking me? Tenofovir disoproxil is in the routine PrEP. And in Descovy, it's tenofovir alafenamide. So changing that salt makes it kidney and bone friendly.
Right.
Essentially, it makes it more stable in the plasma, having a longer half-life. It doesn't travel to the kidneys and the bones and cause those problems. So we can use that for people with chronic kidney disease and osteoporosis or osteopenia. But we can't use it for everyone. So the cost is around 10 times the price of routine PrEPs. So NHS England do set quite a strict commissioning criteria, understandably. And it is for people that have either chronic kidney or bone issues. But there is that option there. It doesn't come scot-free, though. There are some potential side effects.
Right.
Now, there's not enough long-term data of Descovy PrEP for Descovy used as PrEP, but we have been using Descovy as for HIV treatment.
For HIV.
So we've seen in that kind of cohort how Descovy's been tolerated. And we do go back to the Discover trial for Descovy, which is where Descovy was used as PrEP, to have a look at side effects and things there. Essentially, Descovy could cause weight gain. And it's around 1 to 2 kilos over the first year of being on Descovy, and then we see it plateau out. We don't really know the mechanism for this. We don't know if it's because the Truvada PrEP is like weight suppressing. And so when you come off it, you're returning to like your baseline weight rather than Descovy actually causing the weight gain itself. We've seen that potentially it can affect your lipids, so like your cholesterol and blood pressure as well. So it can cause high blood pressure potentially, one study has shown. But it's just a risk-benefit decision that you take. And it's tricky because particularly a lot of people that have chronic kidney disease also have diabetes and also have high blood pressure and maybe overweight.
Right.
So then do you want to protect their kidneys or do you want to protect their cardiovascular health? And I present those two things to the PrEP users that I'm seeing. And we make an
informed
decision and it's a mutual decision and their choice.
Fine. So what if, Steph, you have a patient who comes to you and they just have an absolute phobia for tablets? They cannot take tablets, swallowing them makes them gag, and it's hopeless. And they have tried and they have failed, but they are also high risk for getting HIV. So is there any hope for these people? What do we do with those people?
Yeah, great question. So there is a new injection called Cabotegravir, which is a 2-monthly intramuscular injection.
So once every 2 months.
Technically, there's an optional oral lead-in, so you can take an oral version of the injection for a month.
Same drug,
Same drug, 1 tablet once a day to see how you tolerate it. But this in the studies that has been optional, and then you have an injection after the month of oral treatment if everything goes okay. And then you have another injection in a month that's like a loading dose. And then you move on to the 2-monthly schedule. It's exactly the same as how it's used for HIV treatment as well. It's an intramuscular injection into the bum. And at the moment, it's not commissioned on the NHS.
So basically, by that, you mean NHS is not going to pay for it?
Right now.
Right now, they're not paying for it.
Right now. So it is available in other parts of the world. America have been using it. quite a lot, that they're always a bit ahead of us.
Yeah.
So at the moment, the only way we can access it is something called a compassionate access scheme,
Right.
or it's sometimes referred to as like free of charge schemes. So for people that can't take either of the oral versions of PrEP, so the generic Truvada version or Descovy, we can submit the case to the pharma company Vive and say this patient, under exceptional circumstances, cannot take oral versions of PrEP for whatever reason. So we've had side effects, we've had kidney problems, and the company will then discuss it. They have a panel where they discuss cases every couple of weeks, and they can approve to give us the drug for free under this compassionate access scheme, like a clinical trial. Yeah, there's a lot of hurdles to go through
Of
to try and
course.
get it.
Of course.
You've got to get your NHS trust, governance, sometimes called DTC, Drug and Therapeutics Committee, to approve you to use it as well. And the patient has to consent to
Yeah.
going on to this, and
Yeah.
the fact that their data in terms of any adverse events is reported back to the company. They need to consent for that. But we have had 3 patients in our clinic
Wow.
be able to get onto it. We just had our 4th patient approved last week, which is amazing, and has been an absolute game changer for these people, because they couldn't take oral PrEP for one
Right.
reason or another, and
Right.
now they can take another formulation.
And the protection is exactly the same,
Better.
if not better.
Yes.
Wow.
So it's HPTN083, where it was trialed in, just rolls off the tongue,
Yeah.
in MSM and transgender women, and then HPTN084 in cisgender women. So it's one of the first trials that's trialed PrEP in women as well,
Right.
which is
Right. Right.
incredible. It
Right.
wasn't trialed in the UK,
Right.
but it's been shown to be more effective
Right.
than the standard oral Truvada PrEP, which is amazing.
Basically, NHS needs to get their act together and get it approved for people like that,
Yeah.
right? Because it's this versus another person with a lifelong condition that they may have to pay for if this person does end up getting HIV.
Yeah.
And I think it'd be even more sad because this person took the initiative and actually came to us, asked for help, and we just couldn't help it despite knowing that there is an option available. It's just so happened that NHS doesn't pay for it right now.
I hope so. The kind of commissioning process for HIV changed kind of a year or so ago, where it used to be NHS England that commissioned all of HIV treatment. Now it has to go through NICE. So at the moment, Cabotegravir PrEP is going through NICE. They're
NICE, NICE is National Institute of Clinical Excellence. So this is a governing body that makes all the guidelines or recommendations
kind
for
of decide whether to fund
conditions.
the drug or not,
Right.
and take advice from clinical or the drug company clinical trial effectiveness data, evaluate cost effectiveness,
Right.
and
Right.
then
Right.
make an informed decision. Once that happens, if approved, the NHS then generally has around 90 days to give a commissioning criteria
Nice.
of who we can use it in. So I'm hoping beginning of next year we may have it
Fingers
available.
crossed. Fingers crossed.
Definitely.
Last question. I think we saw something really exciting in the world of PrEP this year. And there was a conference that happened in Munich called IAS. And they spoke about this new fantastic drug, which has shown incredible promise. And I think this name of the study was called Purpose One Study. So can you tell us about this wonder drug and this alleged wonder drug that is supposed to be even bigger of a game changer than Cabotegravir?
So it's called Lenacapavir.
Lenacapavir.
It's a different kind of class of antiretroviral in terms of the way it prevents HIV replication. It's called a capsid inhibitor. Very newly, it's been used for HIV treatment, but now it's been trialed as PrEP. And it was trialed in women, was the Purpose One study. And it was Lenacapavir versus Descovy.
So the bone
And
kidney friendly. Yeah.
that's right. And it was shown to be highly effective. So I think it was around 5,000 participants.
Yeah.
And in the Lenacapavir arm, there was no breakthrough HIV transmissions. And Descovy arm, I believe, around 50, 55.
55.
55.
Yeah.
So groundbreaking.
Yeah.
Absolutely groundbreaking. Another PrEP medication that's been used in women as well. So this was obviously a very large randomized clinical trial. Now they're looking to do more purpose trials within different cohorts. So MSM, injecting drug users. So there isn't a lot of data for PrEP in injecting drug users. So this will be really important data. I think one of the things V possibly has struggled with Cabotegravir is that it wasn't trialed in the UK.
Right.
As PrEP, Purpose 5 is going to be a trial of Lenacapavir used as PrEP in the UK. And that is going to be with kind of any cohorts, any risk, any HIV risk, high risk group. Yeah. And that's going to be starting recruiting as of next month.
Wow.
One of our hospitals near us, King's College London, is going to be recruiting. So I'm hoping that we'll be able to refer some patients onto that trial. We didn't mention actually the dosing schedule, did we? So it's 6 monthly.
Wow.
It's a 6 monthly injection and it's subcutaneous.
Twice a year.
So subcutaneous, just like under the skin, could be under the arm. And potentially, now I don't know if they formulated it this way, but potentially it could be like self-administered.
Wow.
Which would be incredible. But it's 6 monthly,
It's insane, isn't it? So you basically have a drug that no one knew about, and suddenly they try it as part of this huge trial with 5,000 patients. They give it to over 2,300 women, and they follow them up. They give it just once every 6 months. So 2 injections a year.
Yeah.
And 0 out of 2,300 women got HIV. Nobody got HIV compared to the stuff that we're using right now as a routine protection mechanism. And about 50 or 55 people actually got HIV in that arm. So potentially we could be seeing the end of HIV if this drug shows promise in all the other cohorts. Do you think?
If Gilead let the drug be used in countries of high HIV prevalence where it's really needed, then we could,
fingers crossed,
work towards meeting our target of ending all new HIV transmissions by 2030.
Wow. I think this sounds like a very positive note to end today's episode. Steph, thank you so much. I think what we didn't discuss is how many publications you have done in PrEP, how many times
you don't need to know that.
All the work that you do, and you present it nationally and internationally, and you've started your own network of pharmacists who are engaged into similar kind of area of practice called PrEP Pharm Networks. I want to give it a shout out, and people need to go check that out, where you are engaging other pharmacists and healthcare professionals to come join this race to try and end the HIV pandemic. So keep on doing that great work. And thank you so much for spending time with me. And I'm sure I'll see you again.
See you. Thank you. Thank you so much.
Thank you, Steph. Thank you.